Okay. All right. So what I'm going to do is talk a little bit about RVUs and the revenue cycle. And really my goal here was to sort of talk to people and figure out how we're all using RVUs and how we might consider thinking about where all the data comes from and how we should use it and where we should go in the future. I have no conflicts of interest to report, and the only caveat I would make is that I developed these slides before the very recent January the 1st, 2023 changes in RVUs came into effect, but I don't think it really matters very much. So what I'm going to do today is basically define an RVU, talk a little bit about how you control your own RVU production, compare our own RVUs to pediatric endocrine standards, and think a little bit about how we compare salaries to RVU production, and talk a tiny bit about the revenue cycle. So what is an RVU? It's a relative value unit, and these were designed, I'm not 100% sure if they were designed by CMS or by surgeons, but they certainly all work together. And this is a way to rank on a common scale the resources that are used to provide a service. And so we just heard about how the endocrinologist decides that a patient needs a continuous glucose sensor and spends 3 hours educating the patient, etc. And then the physician spends 15 minutes and gets paid approximately 50 times more for that little action. So RVUs are made up of two parts. There's the total RVU, and then there's the work RVU. And the work RVU is the amount of work that's assigned for the physician to do the job. And the total RVU adds in a number of a component that talks about the expense of the practice and paying for your insurance liability. So CMS recognizes that we have to see patients do work and that it costs us to rent a place to do it in, and then we have to pay malpractice insurance. And so what they have done is they've assigned the value of a work RVU. They've assigned the value of a total RVU as well, but I'm just primarily going to focus on work RVUs. And if I ever leave the W out, just assume that's what we're talking about from here on in. And what's very interesting is that Medicare assigns the value of a work RVU, and that value has gone down. Where are we? I had it a second ago. Oh, yeah. That value has gone down from $34 to $32.40 in the RVUs. And so every time you hear something, great news, Medicare has assigned more RVUs for the cognitive specialists. What you discover is they also lowered the price of an RVU. Another thing that's very interesting about RVUs is, what they tell us about what people think we do. So for most people who are pediatric endocrinologists working in academic institutions, we use RVUs as a way to document how much work we do instead of counting patients. So for example, we did 38,000 encounters last year in Cook Children's between inpatient and outpatient, and that was 68,000 RVUs. And when I divide it between all my staff, all my doctors, all my NPs, as if all we were doing is seeing patients, it turns out to be 4,000 RVUs per staff member. But I can tell you that I hardly see any patients compared to someone like Joel. So, when you look at averages, it doesn't really tell you about what someone like you is doing. Let's take a 99214, a moderately complicated follow-up visit. It's assigned 1.5 work RVUs. CMS reckons that takes us 40 minutes, and they assign 5 minutes to read the chart before you go in, read the referral note, read your old note to see what the plan was, 30 minutes or 25 minutes to see the patient, and most importantly, 10 minutes afterwards to do the cleanup work. In fact, that means that if you do the calculations, that for every 30 minutes of seeing patients, they have assigned us 10 minutes to work afterwards. That's 33% of the time, which really means that 66% of your time is seeing patients, 33% is dealing with the aftermath. That gets you to 100%. So this concept that an FTE is doing 2 clinics twice a day to give you 42 clinics a month is incorrect, because an FTE, if they're seeing patients and dealing with all the aftermath and doing nothing else, that's actually 7 half-day clinics of 3.5-hour clinics. So step number 1 is this issue of, when you look at all of the survey data and you read about, well, we converted into FTE equivalents. So his senior people think an FTE equivalent is 10 half-day clinics a week. And so that's an argument that we have to do. So have they rounded everything? So when I only do 1-2 half-day clinics a week, do they take my RVUs and then multiply that by 5 and say that's what I would earn if I was an FTE? So that's important to understand that little detail. So one of the things I want to talk about is, how are we all paid? Unfortunately, we don't have a lot of people in the room. We have lots of people, driving home on the meeting. But, like, how many people are paid by salary alone? How many get a salary with a bonus? And how's that bonus decided? Is it because you were a good citizen, or is it because you did certain RVUs? Is it because you did a hypoglycemia clinic and you did a bone clinic, and we know that takes more time, and so we're going to give you good citizenship for being a subspecialist within the clinic? How is that determined? How many people are paid on a salary collection, plus or minus a bonus? So you heard about, the fact that you collect money, and they divide out the money in the group by how much you collected, but then what about who's going to pay your nurse? And then how many people are on RVU-based productivity? And what difference does it really make? So, and these are important things, because, for example, if you're paid on a collection-based model, which is how we've been paid in Cook Children's, in that all the money we collect is divided out after our expenses between the doctors, what happens when I see a new onset person with diabetes who comes from Mexico, happened to be on vacation in the great United States of America, has got no insurance, and they come in and we spend 2 days looking after them and planning and everything, and we bill for that money. So we generate a bill, but there is no collection. So we recently are switching over to RVU based, meaning that we get paid for all the work we do, but the hospital may not collect money for all the work we do. So that's very important distinction. And some of you might be thinking, I'm afraid to go to an RVU-based payment system, but you could argue that it's actually better, because you get reimbursed for the patients who don't have insurance, whereas when you're paid on a collection-based system, you don't. So how do you control your RVUs? Well, basically, the amount that you earn in a year is affected by the mix of whether you see consult patients, new patients, or established patients, because each individual billing type has a different RVU associated with. So we start off with the 99212, the amount of RVUs is probably 0.8. You get up to 213. It gradually builds up because it reflects the complexity of what you're doing. New patients and new consults. Remember when Medicare decided there was no such thing as a new consult anymore? They're all new patients. The reason they did that is that the RVUs for a new patient visit is less than the RVUs for a new consult patient. And so if you look at what we used to do in the past, now we can't bill new consults for certain insurance plans and for Medicaid, certainly in Texas. So the same work is actually less RVUs. And so you had to suddenly adjust and say, well, I used to build a new patient consult level 4, but the RVU workload for that is the same as a new patient referral level 5. So did we all think about that and make those appropriate changes? The amount of time of clinic time that you do versus on-call duties. Like, so supposing you're on a 1 and 2 on-call, and that means you spend less time in clinic, can you generate as many RVUs in the hospital? So, if you're busy running around putting out fires and you're billing level 1s for all your quick follow-up patients, you're not going to generate much RVUs. So you have to figure out, how do I balance my inpatient service versus my outpatient? And the advantage of inpatient is you're seeing patients at nights and weekends, so you're actually doing 7 days of work versus 5, but how does it balance out? Do I need to schedule outpatients while I'm on inpatient service, or can I actually do it because I'm so busy on the inpatient? You want to think about, the utilization rate of your clinic, which has got really nothing to do with you unless you're an obnoxious doctor who pisses off his patients so much they don't want to come and see you. But usually the utilization rate depends on, did someone call the family and remind them that they need to be there? Do you have enough patients to fill all your slots in the first place? What is the degree of overbooking that you do? So if you know that my utilization rate is only 80%, you automatically book 20% over so you can get to 100% utilization rate. Or do you just say, well, whoever comes, I'll see, and whoever doesn't come, I won't see? Now, if you're on a pure salary, that's probably what you're thinking. Whoever comes, I'll see. Whoever doesn't come, so be it. I got paid my money. But when you're on a degree of productivity, then it becomes very important. And one thing that's very interesting, a simple thing like booking one extra patient to clinic. So let's say you decide I normally see 10 patients. We have a 10% no-show rate. So I'm going to book 11 patients and ensure that I see every time. That's 83 RVUs per clinic per year. So if you do 7 clinics, that's over 500 RVUs. If your RVU target to hit a bonus is XYZ, you can calculate out from this how many extra patients do I need to see to get to my bonus. And you can keep track of it during the year. And let's say you're looking like we get a nice bonus of $5,000 if we see more than 500 RVUs, and you're on track for 499. That's a little bit aggravating. And that last patient didn't show up and you didn't hit your target by 1 RVU, and they said, I'm sorry, didn't make your bonus this year. So how do we know how much RVUs other people are doing? Well, the common way is we look at all the survey data, and there's a whole alphabet soup of letters of all these survey data. And the other way we can do is we can ask each other and we can talk, and that's something that we do not do very well. How many times has one of your best buddies asked you, how many RVUs did you do? How much money did you earn last year? And when is the last time you actually answered that question truthfully? We did a survey back in 2011 as part of the PES practice management. We surveyed 15 hospitals and private practice groups. We sent them a nice letter saying why we were doing it. We sent them a spreadsheet. We said, all you have to do is give this to your business manager, fill in the slots and send it back to us. We don't want to know your patient names. One of us knows your hospitals, but everyone else isn't going to know it. And tell us how many doctors and nurse practitioners you have, how many half days our clinic are done in your institution. So maybe OU would have said, well, between all our people, we have 40 half-day clinics a week. And so we put that in. We found out how many patients they saw. We got them to give us their exact E&M coding. So we learned how many 99213s, 4s and 5s, etc. were done. And we looked at inpatient and outpatient, and we got like a ton of data. And we classified the areas into academic research institutions. So they'd be places like your Children's Hospital of Philadelphia, Boston Children's, where you've got like 40, 50 doctors. They all do a half a day in clinic once a week, and most of their time is spent in research. And then we have academic clinical, which is, by far probably the most common. Your typical hospital, I suspect OU, I would have classified you as an academic clinical, where your people are doing a lot of clinical work. And we saw the breakdown. You had some people doing a lot more academia, teaching and research, but most people were doing a lot of clinical work. And then we looked at some people in private practice, and we wanted to try and understand, what are the differences. We got a pretty good feedback. We got 80% of the people gave us back data. You can see there the breakdown. One of the problems was they didn't give us the data back exactly the way we wanted, so I couldn't analyze everything, but we were able to get a good shot of the data. And what we were able to use was data from 123,000 outpatient coding episodes. I didn't include in this talk here the inpatient work, but 123 outpatients. So that's the equivalent of, like, we have 34,000 outpatient encounters in our institution, and we do 4,000 inpatient encounters. When I say we do 4,000 inpatient encounters, that's a gross under reflection of the work, because we're so busy that we don't bill everyone, and we'll give free advice, we'll do curbside consults, we'll see someone once every 3 days because we're so busy, when maybe we should have seen them once every 2 days. So this is just focusing on the outpatient side. And you can see that in this survey, most of the physicians worked in academic research, 75%, but they only did 50% of the visits, and 5% were in private practice, and they did 22% of all of the visits. So you can see that when you get a survey and you look at MGMA, it depends who answered the survey as to what the results are going to show. So we were able to do some calculations on what the typical productivity was, and I'll make it short, but in the academic data centers, I had enough data on 53,000 RVUs with the right information about how many doctors, how many clinics they did. And what we saw was that our average RVU per patient was 1.69, so that's pretty good. They're spending a lot of time with the patient. They're thinking, they're billing on complex issues, and they're doing good bills. And the typical is about 1.5, so 1.69 means you're spending a little more time and maybe your patients are more complex. They were doing on average 3 clinics a week. They saw on average 5.4 patients per clinic, and they earned 9 RVUs per clinic. Now, this is very useful, because if you are working in an academic research center and your boss says to you, David comes up to you and says, I need you to do 3 clinics a week, and I need you to hit your RVU target of 2,000 RVUs, you're going, well, that's impossible, because, we all earn 9, that's 18 a clinic times, 46 weeks, because you are allowed vacation, even in an academic research institution. You just have to do all the work when you come back. But you can calculate, based on the specific job that you want me to do, how much RVUs could I expect to earn? Here's a clinician in an academic center. They're seeing the patients a little faster, so their RVUs per patient were slightly lower. They were doing some more clinics than the other doctors, but they were seeing more patients in the clinic, so they were generating more RVUs. So a few more clinics, but a lot more RVUs, because they were being more efficient. So even though they didn't quite spend as much time on everyone, they saw a lot more patients. So their RVUs went from 9 to 12.5 per clinic. And if you looked at the people in private practice, they actually were billing high, because they're focused on correct billing and making sure that every dollar that possibly earned is earned. So they're maximizing their billing per patient. They're doing more clinics a week. They're seeing the same amount as the clinicians in the academic centers, and their RVUs are slightly higher, just because they're doing maybe slightly more efficient billing. And so what you could do is look at all of that information, the RVUs per patient, the patients per clinic, the RVUs per clinic, the clinics per week, and you can come up and get a better understanding of what people in different categories of work are doing. So from our study, we were able to see that the academic researchers, when you convert it to full-time, and this is very important, because our decision about full-time is 7 clinics per week. So when you, and times 46 weeks, when you convert it into full-time, and of course there are no academic research who do 7 clinics a week. So just bear that in mind, is that these are the numbers that you see when you look at this data. But the nearest MGMA to the time of this survey, this is 2009, this is 2011 data, show that the average physician was doing 3,631 RVUs a week, and the Sullivan-Cotter, which is another survey, showed 3,284. 25 physicians, 34 physicians. So, which data is right? Which one do you compare yourself to? And that's the whole thing about the published standards. There are tons of published standards: MGMA, AMGA, the AAAP, Sullivan-Cotter. And the question is, who am I being compared to? How many endocrinologists are in the survey? Where do they practice? What's the definition of full-time? And the problem is like I said, that I consider a full-time clinician, because you only earn RVUs when you're seeing patients. So they want to convert you into a full-time clinician and pay you, compare your payment to your RVUs. But, you know, we all know that you're supposed to somehow or other get compensated for teaching and for doing your research, and you're supposed to have time to do teaching, which is why people in private practice do more clinics per week than people in academia. And, you know, is all teaching equivalent, and how much you get compensated for research and publishing. And none of that data is in the standards. So one of the things I did is I looked at the 2019 composite survey data. And so this is a composite of these 4 surveys. And there were 617 physicians. So that's a big, huge number. However, I have no idea if the 72 patients in here and the 320 people in here, how many of them are the same? Because you don't know. And what they showed was the 25th, 50th, 75th, and 90th percentile for RVU production and salary. And so you can see that the 50th percentile, so the mean pediatric endocrinologist, according to this survey, does 3,100 RVUs, earns $212,000 a year. And when you go back and look at what that data was in 2009, very surprisingly to me, I was shocked when I saw this, but this just shows you how useless the data is that look how many RVUs we were doing in 2009 versus 2019. If I'd asked you the question before I put the slide up, do any of you feel like you're doing more or less RVUs now than you did 10 years ago? I bet you all of you would say we're doing more now. But the data doesn't actually show that. Are we earning more than we did before? According to this, we are, but it's really not very much. It's like $20,000 to $25,000 over the course of 10 years. You know, so that's a 10% pay rise in 10 years. That's 1% per annum. There's no one on your staff who got as little a pay rise as you did. That's for sure. Everyone else got at least 3% per annum. So this sort of shows a few things, and one of them shows to me is that the data doesn't really help us understand fully. You know, have any of you asked, you know, 15 or 20 of your colleagues how much you earn, and did, you know, were half of them a little less than 212 and were half of them a little more than 212? You know, that's an interesting concept, because so far when I've done, you know, straw poll surveys, this all is much higher than most people seem to think they're earning at the moment. And so what people do is they draw a graph and they say, here's the compensation and here's the RVUs, and they plot it out, here's the centiles, and then you go and say, well, how many RVUs am I doing? And then you look and see, are you getting the same amount of salary? And this is supposedly how it works. The thing that's important to remember is this graph does not go through zero. So the people who would do 0 RVUs don't get paid nothing, and because they're usually doing something else. So, you know, people try and do the math and say, okay, well, if you get 156,000 for 2,100 RVUs, then you're paying at X dollars per RVU. And why is it different as you go out? Well, because the reality is that most people's salaries are not dependent on their RVUs, but that's how they equate them. You could say, well, are they dependent on their collections? But they do the same trickery with collections, which is they say, well, Thornton, you only collected $100,000 this year, and you only saw patients X amount of time. So I multiply it by this magic figure, which gives me a full-time equivalent. But it's not correct. So my whole point here is that there are lots of issues about how we use the data that's published, and each division chief, well, it's not really the division chief, each chairman uses this data in a way to suit their own purposes. And the question is, you know, how can we use this to suit our own purposes? You know, it's important to remember that RVUs were developed by CMS for adult physicians and surgeons. They weren't developed for pediatricians. They were primarily developed for surgeons, and you can see that if I'm a well-trained ENT physician and I am doing 10 tonsillectomies or adenoidectomies, whatever, putting ear tubes in, and I can do each one in 6 minutes, and I've got 3 OR rooms lined up. So I just walk in, put it in, go into the next one and the next one. That guy is being paid probably, 100 RVUs, and you and I are seeing a really complicated McCune Albright with multiple problems, and we get 2.6 RVUs in the same hour. We both went to med school, we both did the same training, we're both equally good at what we do, but they get paid a huge amount more for it. RVUs for the endos are most often used for productivity bonuses. So how about anyone in here? How many of you is RVU in your productivity bonus or your bonus? So it's almost everyone. Yeah. And if your RVUs are below target, is it your fault or your division chief's fault? Well, I can tell you it's certainly not my fault. It's not probably your fault. But, it's the scheduler's fault, right? Okay, so when you get called in to the chairman and he says, Paul, you only did 4,000 RVUs and I thought you should have been doing 4,500 RVUs. And you say, yeah, but my schedule was built to allow me to do 5,000 RVUs and your staff didn't fill my schedule. Why is that my fault? I was there, I was ready to work. I want you to pay me the 5,000 RVU bonus. Well, he's not going to do that, but it's their fault. It's, did they schedule? So that's where the revenue cycle comes in. What do we do in the revenue cycle? All we do is see the patient and code the visit. We do nothing else. And look at how much stuff is involved in getting that money here. Okay. If your division chief decides that, gosh, I don't want to be on call very often, so I'm going to hire 10 new doctors so that we're all on call 1 in 20, and then there's only 10,000 patients available for scheduling, then you're not going to be have enough patients to see. So that can affect how much RVUs you do, how well your schedulers do the job. If you ever, when you get Epic, have a look at this. It's really fun. You can track in Epic how many patients were scheduled into an individual visit. Okay, so let's say I'm doing clinic on Monday at 10 o'clock. I have a diabetic patient scheduled. I can look and see how many people were actually in that slot. And it's typically 2 to 3 people. So people will schedule 4-6 months out, and they'll cancel 3 months out because they realize it's their birthday. And then someone else will call in and say, I couldn't make it last week. I had the flu, and they can get in because they just happened to call 1 minute after the slot was open, and it fills up again. And then they realize, oh gosh, it's my child is having a party in school that day and they're bringing in donuts. We don't want to miss it. And they cancel, and it just goes on and on. None of that is in your control. If you're on a collections model and your people at the front desk feel very uncomfortable about asking for money before the doctor sees you, just pay afterwards. You probably won't see it again. That's none of your control. So, this is the problem, is that we get treated as if this is all in our control. I asked you to see 4,500 RVUs to get your bonus. You only saw 4,000, and you sat in clinic twiddling your thumbs. Okay, so you caught up and you did some reading, you were working hard, but it's not your fault. And so that's another problem. So one of the things I think is that what we need to be doing is really not comparing each other's RVUs, how hard we're working, is we need to think about what compensation do I need to be earning to make me feel like I'm being paid fairly. And part of that is knowing what the average endocrinologist is. So I've just shown you that the average endocrinologist, according to these surveys, is earning $212,000 a year. And then if you decide, well, I want to earn $212,000 a year, but I don't want to work really hard, then you're probably not going to be employed. Whereas if you say, I'm willing to come in and work as hard as this, and in fact, if I work even harder, will you pay me more? And there is a benefit to the institution for you working harder. I don't think there's a single endocrinology department in the country who makes a profit. But that's because of how they count what making a profit is. So for example, when I admit HI baby that you guys transferred down to me from OU, and they got focal disease, so we put them in the NICU, we do their PET scan, we cure them, we send them home. I just earned the institution $300,000. That doesn't go down on the endocrinology checklist of how much money endocrinology goes in. That goes on the neonatology checklist. And the $50,000 for the surgery goes on the surgeon's checklist. So, this idea that when David and I are called into the top guy, the CEO, and he says, you guys are losing money. We're not losing money. In fact, you can't do without it. So we need to be strong and we need to understand our role in the institution, what we do. You can't have a level 4 NICU if you don't have all these subspecialists. It's okay, yeah, you don't need us. That's fine. Now you're a level 3 NICU. And that's a big problem. So I think what we have to do is, as a group, we have to recognize that our salaries are probably not going up as fast as we think they should. We may have to debate about how hard we should be working in a clinical versus an academic perspective. How many papers is the right amount of papers to achieve your goal, et cetera, et cetera. But what we have to do is figure out a way to at least make the way that we get compensated fair for us. And for example, I would never recommend that you get an RVU target, and if you hit that target, you get a bonus. Why don't you say, okay, if you're going to pay me $10,000 for making 500 RVUs more, just pay me $10 an RVU. And so if I get 400, I get my 8,000 or whatever the number comes out at, $20 an RVU. That would be a much better negotiation skill than saying, okay, yeah, I'll go for the 500, and if I miss it, I don't get it. So I think these are the things we need to think about. And I would strongly recommend that all of you, instead of, being closed-mouthed and not sharing data with each other, like tell each other, this is what we get, this is how we're paid. Help people understand when they go and negotiate. When someone comes to work for me, if we offer them the job and they don't take it, and we discover it's because they got paid more somewhere else, we need to go back to our people at the top and say, hey, I can't hire people because we're not paying them enough. So there's a lot of work we have to do. Right now, I believe we're in a position of strength because we have such a shortage of endocrinologists, and we can give away that position of strength by saying that our nurse practitioners and PAs can do our job instead of us. So actually, we just pay someone a little bit less. I mean, we need their help and they're very valuable. Don't get me wrong. I love my nurse practitioners and they offer a skill set that I don't have, but we have to be careful not to give that away. So, I wonder myself is it our job as division chiefs to negotiate better, to get all of you a higher pay rate? And I certainly, that's what I try to do in our team. But I wonder, are we all doing that? And do all of our division chiefs have our backs? And are they fighting to say, no, I need to pay my people more? And if we did that, how much better would we do? So that would be something I would love to hear. And interestingly, we'll be at the division chiefs meeting this year at the PES. So I think we should be having these discussions with our colleagues as, how many people here asked for a raise for all their people last year? And let's learn and fight from within. So that's all I'm going to say. Thank you very much. Here's a picture of our beautiful campus for those of you who want to come and work for us. And, thank you very much.
Thank you all. What we'll do is I'll let you all stay up there and field virtual questions, and I'll roam with the microphone. Are there anyone out in the audience that has any questions?
That's all for you. By the way.
Okay.
No, none of that's for me.
Let's start with an in-person question, then we'll just kind of bounce back and forth.
Well, we got no virtual, so you don't have to worry about that.
Okay.
We've amazed everyone.
Quick question, and is there any advocacy being done to balance out the surgical and the medical RVU compensation? Is such a discrepancy?
So the answer is yes, there is, and it's not working. So every time we make a gain and we get a recognition that medical and specifically cognitive subspecialists deserve to be reimbursed more, they have this big thing, they make all these changes, and then all the surgical groups come in and say, yeah, but there's only a pie of this size. So when you pay them more, you're paying us less, and we're not standing for that. So it happens every time this comes up. There is a negotiation. They recognize that we deserve more. They'll either up our RVU numbers, so they'll give us more RVUs for a given thing. So remember, there was this great one that came in 3 or 4 years ago that said that if you were a cognitive specialty, you got this extra amount of RVUs per encounter. So for us, actually, our RVUs per encounter, I think it was 2022, went from 1.5 to 1.8 because they granted us this fabulous new thing. The problem was they dropped the reimbursement per RVU. So the answer is yes, there's a lot of advocacy, and unfortunately, the result is it's not working.
Sure, let me go with Jonathan here.
All right, thank you both for great talks. So obviously get the opportunity to talk with Dr. Sparling regularly, and we talked a little bit yesterday. So I guess 2 questions. How do you see, your caveat, how do you see the inpatient changes for this year affecting RVUs? And secondly, is there an amount, I know we're bad at sharing salaries, an amount that would you think kind of have our trainees and people who can endo actually maybe commit more to endo going forward?
I'll have a go, and then you can have a go. Yes, there were significant changes in 2023 on the inpatient side. Unfortunately, they gave and take all with the same hand. So they said, okay, we're going to eliminate the difference between inpatient observation and inpatient admissions. We're going to make them all the same things. But then they went up on the time for some, down on the time for others. So I don't think it's going to make any difference. They just rebalanced it is all they really did. And this is like the games they keep playing. It looks like, oh, this is great. Okay, we're simplifying, we're doing all of these things, but the reality is that it's just a shell game, because they perceive the pot of money as being the same. And so you go up in some, you go down in others. What was the second question you asked me?
Is there an amount?
An amount. I think that if you are a subspecialist and you've done extra training, you should be paid more than a general pediatrician. And right now we're not. So I think that would be a number that would be fair, is that you spent 3 more years, you deferred earning, over $100,000 for another 3 years. And, I'm a believer that yes, a general pediatrician sees more patients in a day, but they're all level 3s. They're quick visits, solving quick problems, and we're taking more time thinking. I think that would be the solution. I mean, if you look at as a general rule, if you line up all the specialties and look at who gets paid the least, it's the bottom 3 are probably endocrinology, metabolism, and genetics. Psychiatry is a little bit a bit above, but so nobody wants to go into those specialties because they're thinking, well, I'm not being they may appreciate the lovely work I do, and our children will appreciate what we do for them, but you're not getting reimbursed the same. So personally, I think we got to be paid at least the average salary of a pediatrician to at least get level.
So yeah, absolutely. So it's interesting that data exists of dollars per RVU, and a lot of places that's how they're now establishing the base pay or the bonus pay, and those numbers exist across all subspecialties. So again, that's the fun thing about the game, right? Is that surgeons actually earn roughly the same dollars per RVU. They just have the ability, based off of the things that they're doing, to earn more RVUs, right? You look at a endo's RVUs versus a surgeon's RVUs or a pediatrician's RVUs. It's interesting. So now there are some subspecialties that earn considerably less per RVU, which is odd. And so that's one of the advocacy things. Your first question, it's going to be place dependent. So if you come to PES, my talk at PES is I'm going to show one of our NICU babies, because at our institution, seeing a NICU baby was always a level 1 consult every single time, because they wouldn't accept when we said review of systems unable to be performed because patient is an infant in an isolate, right? They would, since that we didn't do review of systems, it didn't count. So they automatically the lowest level visit. So now that it's medical decision making, I expect our RVUs to increase because the billers will ignore that requirement at our institution. But if you talk to other institutions, fun thing, billers at other institutions do not follow that rule. That's just our billers. And so that's where the advocacy internally of with the whole revenue cycle of who's doing what, where, when, why, and how for our record keeping is important. So that's why we're lucky on the outpatient side, we're deciding our level of visit. But frequently, especially with Epic, especially with other places, people are starting to define, oh, no, the EMR will decide all of that for you. Well, then, okay, you have to be better about billing and you have to be better about documenting. And okay, so I need a scribe to do all that for me, but scribes cost money, but yada, yada, yada. So it becomes down to what's at each individual institution as well, because you don't know what's happening once you've signed that note and walk away, then literally 6 to 9 months of work that goes in behind it that then actually applies to, okay, well, we got this much, that's that RVU. And maybe that was wrong. So
I'm just curious, and I'll move back. But the thing I think that strikes me from your talks and just in general and discussions is, I mean, I feel personally, and I think talking with colleagues both at Cook and outside, I mean that our volume and complexity of work has gone up greatly, and we do things that are very precision. And really have, very, strong impact on the health, quality of life, et cetera. And, just the overall, how the patient, whether they're inpatient or outpatient is going to fare in the system. And so we do a lot that supports, directly and indirectly our colleagues. So is it even conceivable that an institution could recognize the reality and recognize the necessity and provide like some type of support to help us, and also to again make it so that people that are passionate and that do want to do endocrinology, where it's something that passes the muster for them as far as a quality of life and economic reality, that they could do that if they wanted to.
I think that's doable in an institution, but I think that's where, and again, with our institution undergoing its transformation, it's been very intriguing to see. We're both kind of advocating talking, right? Not just to us, right? The biggest advocate our section has these days is our NICU. Our NICU is literally saying, we can't run without endocrinologists. You're going to have to figure out how to take care of the endocrinologists. And the geneticists and the yada, yada, yada.
Right.
And so it takes those type of relationships at the same time. And I mean, we're data-driven field, showing the data and saying to the institution, you want this, I physically can't. Our scribes, they said, oh, no more scribes. I'm gonna have to go to the institution and say, great. We're cutting our visits by 2, but that means that, because we added 2 visits because we had scribes to pay for the scribes. So we're cutting that back, and you need to cut back my RVU goals because you can't look at my old RVU goals anymore. But that level of advocacy and discussion has to occur so that they understand, so that the group as a whole is risen, so that when residents look at us and say, oh yeah, that looks like that's something I want to do. It's because it's actually got support, that we're not fighting on our own. So I think those interpersonal relationships at every level is required. So,
yeah, I mean, we've heard about hospitals where the whole endocrinology team decided, you know what, we don't want to cover all these different hospitals. And when they pulled out, those hospitals then said, it suddenly dawned on them, oh my gosh, now this is going to affect our NICU and our PICU and our bone marrow transplant team. And these are all the people who have big say in the institution. And so then suddenly we became valuable again. So I think it's important that, you know, our colleagues all join with us, and that's and you know that's a thing that it's relationship building. It's talking to everyone else and getting them to say, like, unlike what the surgeons are doing with the RVU debates when it comes to CMS, they're saying, yeah, we think it's great that you pay the endocrinologist more, but don't take it from us. And that's the big problem is, you know, if the NICU is very supportive, you know, but it's like, don't take it from us. Who are you going to take it from?
I mean, I guess the other question is, you know, obviously there's only a finite amount of money that comes in at some point and has to trickle through all of those. So is there, you know, you can say, oh, let's go after the administration and the CEO and people like that. I mean, is that, you know, heading down the path of class warfare, or is that realistic, or probably somewhere in between?
I don't know. It's difficult, you know, like David showed us a couple of hospitals who made a lot of losses last year, but there were a lot of hospitals who made a lot of gains last year. And, you know, the question is, it always comes down to the same thing. How much profit do you need to make? You know, is $100 million profit a year enough? Does it have to be 200? Does it have to be 300? How much money do you have to have in your war chest? Is like 2 billion enough? Or, you know, does it have to be 3 billion or 4 billion? You know, it's very frustrating when your institution makes a lot of money and you feel like you're not earning a fair salary, to look at that and see. So, you know, it's always important for everyone to understand how their institution is doing as well. And, you know, when you look at going to work in another institution, one of the people you should meet on your interview round is the CFO of the institution. And you should be asking them, how much money have you got in your reserves? You know, like, is it 1 billion or 2 billion or 3 billion? How much days cash on hand do you have so that if Blue Cross decides not to pay us, we can survive? And, you know, like when you start hearing, oh, we got 600-700 days cash on hand, you know you're in a financially sound place. And now the question is, will they pay you equally well as they're, you know, basically doing? And, you know, like if you're in a hospital and they're making $2 million profit and it's a 700-bed hospital, they are so tight on the margin, you are not getting anything. You know, you have your only diabetes educator leaves, sorry, we're not replacing them. So, you know, how many of you, when you interviewed for your first faculty position, met a financial person from the institution other than maybe the benefits lady? You know, that's a very important person to talk to.
So I don't think it'll be class warfare, but like having that. Okay, so I'm a little the product of a little bit of knowledge is a dangerous thing, right? I had a course, and at the end of the course, I was able to have these discussions, and I was turning to some other physicians that were talking about this very stuff. And one of the physicians turned to us and said, we are all now second-year medical students, right? We all know the words to be just dangerous enough to have conversations like this. But, you know, it comes down to the conversation does have to be had. How does that person add value? So that's where I, you know, point out, like, what's proper staffing. If I only have one MA, that one MA can only book 3 patients an hour tops, right? So we have to know that conversation. Well, that's easy to have that conversation. The VP of external relations may do some amazing things, but are they generating revenue for the system too? And so the system has to be operating, thinking in that same way too. And I think that's the hard thing for us as pediatricians and us as pediatric endocrinologists specifically, is that we have not been in this conversation, because what's most important for us is to see the kid. It's to have that kid not be admitted for DKA next year. So that's the balance, is we're used to, okay, whereas my brother, the cardiologist, is like, no, I will not see that patient. So it's an interesting sort of situation.
Thank you both for excellent talk and insight, something that we do not talk often. So that was really good to hear from both of you. Talking about scribes, do we have any data, or, you know, if we had like scribe, you know, the 10% of the time that we spend post, and then we'll be able to see more patients. So is there any in pipeline, you know, adding scribes into our system?
We have to generate that data ourselves. No one will do it for us. But like for us at OU, it was they came to us and said, adding 2 patients a day, you pay for your scribe. That's how you can get a scribe. And that's now gone away for other reasons. So garnering that data is important. And I would also say in this conversation, we have to be very careful for them to not be able to say we gave you dictation software, because a scribe and a dictation software are not the same thing. A note, like I can type faster than I can talk. You all are tired of hearing me talk, right? If my notes were me talking, they would be 40 pages. So, and a lot of errors and run-on sentences. So whereas a scribe can adequately do that in the moment. Right now, again, technology, very frightening. There are AI systems that are currently being tested that can take a natural conversation between you and your patient and turn it into a note. So that's actually being looked at, right? I mean, we all hear about ChatGPT in the news and stuff like that, which is, AI generating what sounds to be a relatively intelligent, discussion. That stuff's probably coming, and that will be great if it's applied accurately. But what are you going to have to do at the end of that visit? You sure as heck better review it, right? What's the danger of copy forward is that you copy forward that this patient was hypokalemic yesterday when they were not. Well, if the dictation software or an AI generates the wrong thing, what's the medical legal document? It's the note in the end. If you don't write it down, it didn't happen. So it's a balancing act. But for now, what's the best version of that? Yeah, absolutely is a scribe. But we have to be the ones that generate that data, and we do, right? Our section overbooks it. Our section schedule utilization rate is 110% roughly, with about a 20-ish% no-show rate. And there's beautiful.
Sorry, you're at 110% utilization rate
with a 20% no-show rate. So we're already overbooking. Yeah. But and this is where having these conversations, the VPs have these conversations. And there's it's Erling's law. There's this beautiful graph that is 80% utilization. And this is not just to medicine. This is business in general. 80% utilization, everything beyond that, the amount of effort increases exponentially. Why does every hospital crash in September? Is because it goes from an 80% utilization rate, and then everybody gets RSV, or how it used to be, to 100% utilization. The hospital can't handle that exponential increase in work. When are we comfortable? Right around that 80% utilization rate. If we get much above that, the amount of effort going into the system does not yield adequate returns. So how do we get down to that, or how do we make that 80 to 90% utilization work better? Scribes, things that take the work off, so that even though we're still doing the work and we're trying to reach those RVU goals, it's possible.
Yeah. The other side to that story is that you need to get it to 80% utilization to pay all your costs. When you get to 100% utilization, you have no additional costs. I mean, you've minor, like you have to pay for the IV fluid, but that's just profit. The point is that when they go from 80% utilization to 100% utilization, the profits double. They don't go up by 20%. They double. And so that's a little bit like why using a scribe, if it helps you see 2 new patients a day. I mean, you can calculate out how much money that is. And I've given talks before, and I've said, what if the doctor calls every patient and tells them the results? Okay, that's a total waste of our time. Okay, the only people who can earn money for the institution are the doctors and the nurse practitioners. Seeing patients is the only way you make money, because if you don't see patients, you don't order tests, you don't do x-rays, you don't get admission. So if we're not seeing patients, there's no money being made. So our job should be to see the patients, and everyone else's job should be to help us do that the most efficiently way we can. And if a scribe gets you to see two new patients, and that's all profit, then you can figure out how much money you generated seeing 2 new patients and how much you have to pay a scribe. And it doesn't take a lot of our work to hire someone. So like 1 new patient a day almost gets you an MA for a week. so you can do all that math and figure it out.
And hospitals
yeah.
know this.
Yeah.
So hospitals know this because what did it used to not be? It wasn't hospitals, or it wasn't hospital systems. It was hospitals. Hospitals are like, well, we need more patients. What are we going to do? We're going to combine with outpatient practices and make it to where you must send your patients to our hospital. So they know that that's the revenue source. They know that that's the key. And then, but they're always going to say, oh, it's the doctors and the greediness that is driving all of this. No. It's the system. No, the system is set up to do all of this. It's on us. This is terrible to put it this way, to take advantage of that. We can, as long as we're speaking the same language, that then it starts generating the positive thing. I can say 340B clinics are wonderful, right? But if I'm not seeing growth hormone patients, that 340B clinic is a waste of money. So we have to, so even though that money is not attributed to us, so we have to also keep track of that, right? We need to know how many, when we order a lab, that doesn't generate an RVU for us or money for us, or when we see a kid in the NICU, or we send a kid to the NICU, exactly, right? But certain medical systems do track that. And those are the systems that in my experience, value the subspecialists, because they're the ones that see that Peds Endo did 20,000 labs last year. That's revenue to the system. So anyway.
Thank you both so much for this discussion, and I think it's something important that needs to take place. I'm a first-year fellow. Last year I was a chief resident, and I got to be at the table for some of this, see how some of the sausage is made, and just looking to the future as a trainee. I'm curious if when we're talking about collective bargaining, negotiating between the cognitive non-procedural specialties, is this a chicken and the egg situation of what is more achievable, what is more realistic? Is it banding together and having a larger bargaining power within a single institution, or at a national level with more of the weight, perhaps by numbers and by more systems? Again, this is like, how do you eat the buffalo, and it's one bite at a time, and this is not a solution that's going to arrive tomorrow, but just future casting. It's interesting to me as a fellow to see what the future might hold.
I'm going to yield my time to the gentleman from Texas with experience and his thoughts.
Yeah, I mean, we've been trying it for years and it's not working, so we have to change. I mean, I think CMS and these people do understand. The problem is the surgical subspecialties have so much more power, and every little gain we make, they just nibble it back away again. And, they're just not happy if they earn less than $1 million a year. And, if we have to get a fair salary for what we do, as long as it doesn't come out from them, they don't care. And, CMS, which is the guide of everything, because even though we don't see Medicare patients, it doesn't matter, because what CMS does, the Medicaid follows at a lower pay rate, and the commercial insurers follow at a higher pay rate, but they make more stringent rules about it. So it's very difficult. I mean, the PES is very concerned about the fact that our match has been running around 50% for the last few years, and their focus has been primarily on, let's get medical students interested, let's do the SEED program, and all of these great initiatives to make everyone understand how wonderful endocrinology is. And how many times have I heard at a PES board meeting, guys, we have got to stop whining in front of the medical students about how miserable our life is and how little we're paid. Like, stop talking like that. No wonder they don't want to come. But I don't see making them more interested is the issue. I see making it more valuable and worth their while. Why would I do 3 years of extra training when I could be a pediatrician earning $250,000 a year for those 3 years, and then you want me to take a job that will earn even less? So,
and work harder too.
Yeah, work harder. I mean, we can all figure out, how hard we individually want to work. I mean, I don't know if your guys have the option, but all of my guys have the option to say, I only want to see 10 patients in a half day, and someone else says, I only want to see 7. And we're okay with that because everyone's paid on productivity, because all we do is clinical work. So we don't have to take into account how much teaching you did and how many papers. So it's real easy as a clinician to figure out, how to fairly pay someone. And it's real easy for our clinicians to determine how hard do we want to work. Now, if someone says, I want to come in and see 2 patients a day, and now you're taking up an office and a clinic space and you're not allowing me to utilize it, that's a different problem. But as a general rule, I only want to do 6 days a week, 6 half-day clinics a week versus my 7. We're okay with that. But we have to get the work done, so we need to hire more people. And so little things like that are doable, and that's part of the quality of life. But that's not the same everywhere, because if you're in a department and we're paying all of our doctors $180,000 plus an RVU bonus, and then Jonathan decides, well, I only want to see 5 patients a day because I'm not interested in my RVU bonus. I want to go home and play with my kids. Then everyone else is like, well, how the hell is he getting away with that? So depending on how you structure everything, allows you to look at those things. But that doesn't answer your question, which is, where do we go in the future? And I don't know. I think the reality is that people are either going to do endocrinology because they just love it and they couldn't care less how much they get paid, or they're going to do endocrinology because, gosh, I love it as much as general pediatrics and I get paid the same. So let me decide which one will I do. But if they love it the same and they get paid half the amount, why would you do it? So I think we have to fix the pay.
With all of these shifts for recruitment and lifestyle and things like that, I've started thinking about, and I haven't done any math on it yet. I want to look though, is right. The concept of RVU as incentivization makes sense to us, bonuses, but the same is also true. People can make the choice in RVUs and say, you know what, I'm okay earning less money with a lower RVU goal. And I don't think the system, I think this is where I frequently think about, and we have to think about as trainees and for our trainees and for the future, that, that 24 hours of our day, it's a discrete amount of time, and provider goodwill is not an unlimited resource. And so having doctors start to say, you know what, you can yell at us all you want that your next available is 5 months from now, but we're not going to work harder because we're happy with what we're earning. The system, that's when the system suddenly realizes, oh, wait, maybe we don't have enough people in the system. And see, so I think it has to be on an individual basis, but I think it also has as a group basis, it has to occur. It's hard on a system-wide basis because conversations will be had with surgeons and they're like, oh, no, we don't worry if we make $100,000 less a year, which I've actually heard a surgeon say. And then that can't be applied to a pediatric endocrinologist. So there has to be some internal banding together with outreach.
Right, and we have to be able to take care of all the patients.
Yeah,
so,
in the end.
So,
right.
so that means
just a few more.
So if we all want to see less, that's okay. Then we have to hire more doctors. But what if there's no doctors? Now your service area is now being underserved. So these are the little dilemmas that we have to deal with, which is, yes, I respect that you want to see less. Can you wait till next September when I hire a new doc before you cut your clinic? Because, it'll just make everyone's life miserable. The longer your waiting time goes out, the more miserable everyone's life becomes, because you start getting more PCP calls. I need you to do a favor. Can you bring this person in? They know someone on the board. All this stuff starts happening because, and you spend all your time trying to tell them how to manage the patient on the outpatient. Okay, you need to put them on 12.5 mics of levothyroxine per kilo per day and check their blood work in 2 weeks, and then adjust it based on the free T4, not the TSH, because it won't come back, and it's blah, 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 blah. And you just did all that for free. Whereas if you said, if you said to me, I'll just see him tomorrow, you earn money. So the longer your wait time, the more inefficient you become. And that's why I don't like long wait times, because it makes everyone less efficient and you do more free work.
Real quick, I'm looking at our time here, but is there anyone on the virtual that has questions?
So Dr. Schaub from OU has said templates will help in Epic, but the absence of scribes but then we've been accused of note bloat when introducing them, which is a real thing, right? We want narrative medicine is a thing, and I think it's important. I
Right.
think scribes are important, and an adequate medical record is important. But at the same time, yeah, we've got to be able to, with all of this, right, we have a role to play, right? We should be seeing patients. We should be writing good notes. We should be taking good care of patients. But at the same time, it's going to take money to do that.
Yeah, and here's the thing. Templates don't make the plan clearer. You still have to write the HPI. Templates are great for systems review, physical exam, family history. It slots all in, you pop it in there. You know, I'm of the opinion that I don't need to see all the labs in the note, because if I want to see the labs, I go to the lab section. So you don't have to bloat your note up with that. But what you have to do is you have to do a good history, and you have to do a good assessment and plan. And that's where a scribe, or like I use direct transcription, and I say to the family, okay, here's the plan. And then I dictate the plan, number one. And then they say, gosh, I'll never remember that. And I say, don't worry about that. I'm going to slap that into the after visit, cut and paste, bang, into the after visit. And then I say, you know, have I addressed all your concerns? And they know what I heard, because they heard me say what my impression and plan was, right? If I go home and do that in the evening like you, at the end of the day, your patient is not 100% sure that he heard what I said. And I know I came in here because I'm worried about my thyroid, and he just said, you know, you're too fat because you're eating too much food. So he didn't hear me, but he already saw that the TSH was normal, and so you don't have a thyroid problem. But if I write in my note, and so that's a long way of saying, yes, templates are great, but you can't template everything. And that's why you have to be efficient, and scribes, or if you're just a good typer, like most of you young people are really good typers. I can't type to save my life. So that's why I use voice transcription, but you know, it has its fun parts when you read my notes.
I agree. I think, you know, templates are good, but you really do have to. I always try to say, you know, I want to know what was Joel thinking. So either I want to look at my note and say, what was I thinking 3 months, or et cetera. Or if, you know, Paul Thornton picks up my note, he's not like, what the hell is Joel thinking? You know, he can look and then he can say, you're an idiot. But anyway, one last question for you all. So we've been talking about the financials. Is there any way to change the dynamics on the non-financials? So the quality of life issues, can you all see any way forward from that? So, you know.
Yeah, I mean, I think if you can get the financials right, it then gives people the opportunity to make quality of life decisions. And I mean, you know, for us, the way our institution works and the way we get paid, we have that ability. And, you know, people still are stressed out. Like, don't get me wrong. It's not like all my docs are the happiest people in the world. I mean, they're all stressed out. They're all working too hard, but at least we have an option to say, gosh, I took a week on call. I'm going to take a day off afterwards. And yes, you will earn less money, but now you're recovered and you come back on Monday and you're ready to go. So I think allowing quality of life issues to come in that doesn't interfere with the team dynamics overall, and allows us to still take care of all the patients. And I keep coming back to the biggest problem is we can't hire enough endocrinologists. So, you know, if we had 15 instead of 12, the quality of life is probably going to be better. We may earn a little less, but we're probably willing to pay for that quality of life. But that's a difficult problem. So do we hire a ton of PAs and MPs? And don't get me wrong, I'm the biggest supporter of MPs in the practice and fought hard to get them recognized by the PES. But at the same time, we have to be careful because, you know, they didn't do 3 years residency, 3 years of fellowship, and they're really wonderful at, you know, at doing the things that they're good at, and we have to use them to do the things they're good at. So that's why many nurse practitioners come from being CDEs, and then they see patients with diabetes because they're really good at that. But you give them a pan-hypo pit, and that's a little tricky, and you can't expect them to be as good. You can't expect them to know all the nuances of hypoglycemia and all of that stuff. So I think that's why we have to make sure that we train enough. Now, there is a question about, what about changing the time of endocrine fellowship in the pipeline? And so that's been discussed at length in the PES and in fact by all of the cognitive subspecialties. And, there's a little divide coming up, which is if you want to work as a clinician, why should you spend a year doing research or 2 years doing research? Why don't you do a 2-year fellowship? You see patients the whole time, you learn how to be a good clinician, and you get out there and go. And there's no reason why we couldn't do that. We could have, a fellowship style, like an MD, PhD type fellowship for people who want to become basic science researchers. We could have a clinical fellowship. All of those things I think are great solutions. And 2 years of full-time clinical work as a fellow versus 3 years where you do 1 year full-time, 2 years research, and you cover the first year fellow at the weekends, you're getting way more clinical experience. And look how many of us now are being clinicians. And, so we really need everyone to be trained to be clinicians. So I personally would be very supportive. But I also recall, the good old days when we were in training and we did 130 hours a week. Like we did learn all that time. I know we slept sometime, but you also have the danger, in the hospital. You also have the danger that if you shorten the time, your experience level drops, so then you have a longer learning curve when you become an attending. So there's pluses and minuses each way. Do you want to address that one there?
Let's see here. I want to see the beginning of it too. Oh, yeah. So somebody's talking about RVUs and kind of how they're value based, but then it's being misled by a payer. That's and so that's the tough situation is that what type of value are we then providing? And there's actually some data, right? This concept of value-based care where we're providing a certain amount of care and it right for a certain contract, and that comes back to us. And interestingly, that data is starting to show that it actually isn't helpful. So it helps as a tool, but it's not the primary way. So again, I do think that this comes to, in terms of, it's talking to CMS, it's talking to our payers, it's talking to people, and everything that we can do for advocacy to decrease administrative load. I think that's always going to be the key, right? One of the best things about OU is that we pretty much don't do prior auths compared to lots of places, but that's because we have people in place to do them. Because having a physician do a prior auth is the largest waste of time and money on the face of the planet. So the amount of times that I've said, when I've asked, what is the negative outcome of not providing this treatment? And I've just said death. And then things get magically approved. Well, there's a reason, right? Fine, make me do prior auth for peg asparaginase. I'm not writing for peg asparaginase, but having to do prior auth for injectable solucortef is a ridiculous waste of everybody's time. So anyway. We've gone over our time and I hear people, I think. So yeah, we can leave it. Thank you all for listening to us rant. Yeah, I only got paged twice while we were up there.
That's good. I'm glad they respected your time. I'm sure they were thinking about you.
No, it's okay. It's the so, but I'm just curious. Not very long. All right. Yeah. Yeah.